have been playing with me all week with the interventions thing. So a lot of this stuff is not going to be totally of relations. They have about 1,000 of them around the United States. Free clinics and decision making. Testing the relational health competence model has been another way of demonstrating the importance of good relationships and communication and health outcomes. And then one of my earliest studies was many years ago, in the early 80s, I worked with the National Cancer Institute on evaluating an online cancer treatment system called PDQ, Physician Data Query. You can tell by the title that they weren't designing it for consumers. They wanted the problem was that the National Cancer Institute realized that physicians who were in the community were not part of major medical centers, were using outmoded forms of treatment. That new treatments were coming along, but they weren't being adopted. They were using the treatment strategies they had learned in medical school. So they wanted to disseminate the latest and the best information about cancer treatment to these physicians. So they developed a really robust, powerful, integrated online health information system, treatment information system, that would provide information about the latest and the best treatments, prognostic information, clinical trial information, references, and even cross-disciplinary consultation that was geometrically matrixed to where people live, geographically matrixed. And so they developed the system, and then they put it out there, and the utilization was very, very low. They spent several $1 million designing it. So then they contacted me and said, can you help us figure out why nobody's using this system? The problem was they were like 10 years ahead of their time. At the time they built this in the early 80s, most doctors had computers, but they were not networked computers. They didn't have modems. They were using them basically as word processing. They're using it for appointments and record keeping. And the doctors themselves were not using the computers. They were having, you hear a million doctors saying, oh yeah, my girl uses it, which they meant my receptionist, or sometimes my nurse, which is a pretty pejorative way of saying that. But and so what we had to do is to figure out a better way of getting the information out. One of the things we did in the study was to do a computer record analysis to see who was actually using PDQ. And lo and behold, we found out that one of the biggest users were consumers through the Cancer Information Service. That PDQ system was being made available to the Cancer Information Service so doctors could call them and ask for information, but somehow the information got out that these medical information was available and consumers were calling and asking for information. The American Medical Association at the time had been lobbying the National Cancer Institute very hard not to make PDQ available to consumers. They figured that their argument was the information would be scary to them, they would be confused, they would be harmed by the information. But I think the real issue was that they didn't want consumers second guessing their physician or suing them for not engaging in the latest and the best treatments. But the information got out, and next thing you know, PDQ information is being used by consumers all the time. So one of the things that we did to try to improve this is we provided different training for doctors to get access. We tried to make it easier. Now PDQ is integrated into the cancer.gov website that the National Cancer Institute puts out. They also are licensing PDQ information to a variety of nonprofits and organizations, cancer-related organizations, so that people can get information even if they don't want to go to a government site. They also provide the information through a telephone hotline, and there's lots of ways of getting. They made the information available at multiple levels of literacy for professionals and to consumers. And now they also have feedback systems built in through live help, where people can ask questions and help getting the information they need. And we talked about the care coordination model. That was clearly to try to improve treatment. And then the Gala program is that we find that one of the best ways of improving treatment is by encouraging consumers to be more assertive and more involved, and provide them with more support and information, not only from professionals but from peers. All right, survivorship. Survivorship is basically a very happy issue, particularly in a lot of serious diseases like heart disease and cancer that were always, considered to be deadly. Most people are actually surviving. The vast majority of people who are diagnosed with cancer do not die within 5 years. That's the survivorship, goal they set. You are a long-term survivor if you survive 5 years after treatment. And now people are surviving 10, 20, 30. Most people who get cancer treated like it was a chronic disease. That doesn't mean that it's not a debilitating problem. And often the treatments for cancer are as bad or worse than the problems you get from getting cancer. Because most of the treatments are very invasive, like chemotherapy that kills off good cells and reduces your immunity level, and invasive surgery and removal of organs. This cannot be good for you, and it causes lots of problems. Plus, people have tremendous concerns about reoccurrence of major healthcare problems and uncertainty about what to do about it. So one of the things we need to do is to help people readjust to life after treatment and to reintegrate into their world. Provide social support and therapeutic communication for people who are particularly worried and concerned. Help people learn to live with uncertainty, primarily through providing access to social support. And then support palliative care that promotes reduction in pain and suffering so that people feel more comfortable. One of the biggest problems with invasive treatments, regardless of what for, is that it hurts and people are not comfortable afterwards. We need to find ways of making these treatments less painful and less debilitating. All right, so here's some of the studies I've been doing. I've been looking at calm competence, social support, and coping. And we found out that people who have greater access to networks of support are much more effective at surviving and coping over time. And one of the biggest issues for long-term survivorship is connecting to people, to networks of people who can encourage them and empathize with them and help them and support them in a variety of different ways, emotionally, instrumentally, financially, in a whole range of ways. Cancer survivors' information-seeking behaviors is that one of the big problems that cancer survivors have is they don't have access to the information they need about what they can do about problems, or what their risks are, or when they need to engage in screening behavior. It turns out that cancer survivors have a greater risk for reoccurrence of cancer than people who have never had cancer. So they have to be particularly vigilant, and they need to engage in screening and also be very good about prevention behaviors. I did an interesting set of studies with one of my doctoral students a couple years ago based on HINTS data to find out whether cancer survivors knew more about screening and were engaging in healthy behaviors at a higher rate, such as eating healthy and drinking less and smoking less. And our hypothesis was that they would, because they would be very sensitized. And lo and behold, we found the opposite to be true. That people who were cancer survivors were actually eating worse diets, were exercising less, were smoking more, were not engaging in screening, and we did follow-up with people to find out why. And they say, well, hell, I've had cancer, I'm not going to deny myself anything anymore. Life is short, I'm going to eat whatever I want, I'm going to smoke. And they weren't really recognizing that they were at greater risk for recurrence. And so I think what happens is that the providers, when they found that they were survivors, basically dropped them and went on to patients who are newly diagnosed instead of really educating them about effective survivorship. And so this becomes a communication issue of providing greater support and access to relevant information about survivorship through this group. Communication and pain and symptom management. I've been doing some work in this area, and I've got a model that I designed that basically suggests that the more information and communication people have about their health problems, the more in control of those problems they can be, the more they can manage those problems. And we've been testing this out with pain management. Most people who do pain management treatment treat it like it's a pharmacological issue. And basically the only way to deal with pain is to numb people, to give them drugs that often zone them out and sometimes are addictive. And I really don't think that's the only way of dealing with these problems. In fact, a lot of complementary and alternative strategies for dealing with all kinds of negative pain, nausea, insomnia, depression, actually work very well. It turns out that one of the major strategies for dealing with these problems, one of the miracle drugs, is exercise. Unbelievably, that if you suffer from fatigue, this is counterintuitive, but if you suffer from fatigue, the best thing to do is to engage in moderate exercise. It starts to give you more energy. And if you feel nauseous, one of the best things to do is to walk. And and if you have no appetite, the same thing. In depression, exercise is really a powerful thing, but people don't know that. And so we need to communicate that there are different ways of dealing with all of the different symptoms that people have that make them uncomfortable. And we also have to give them more sense of control. One of the things I've been really interested in is the use of information technology as a way of helping people chart their symptoms, to understand when they have problems and what they can do about it, and to communicate that information to their caregivers, so if they do need drugs, they can get it right away. And they can find out ahead of time, so if they have a migraine coming on, they can detect it before it hits. And then they can engage in strategies either to prevent it or to minimize the symptoms, but also to develop strategies for coping more effectively. So, and communication has been shown to be as good a factor in many cases as drugs for dealing with negative symptoms. E-health and palliative care, that's what I was just talking about. Health behaviors in cancer survivors, I talked about that, is that we need to encourage cancer survivors to be more vigilant, and so we need to use campaigns for that. The care coordination program we talked about is that part of the care coordination program is helping people be more in charge of their care and more proactive in maintaining their care and keeping them out of the hospital. My recommendation is to stay away from hospitals as much as you can. Only go there if you have a really serious problem. They're very dangerous places. The cardiac advanced planning program is also about helping people to stay independent, to learn what they needed to do on their own, so they didn't need to spend time in the hospital. But if we don't do a good job of educating them as they leave the hospital, they become more dependent on the system. And that's become a really big problem for veterans. A lot of veterans actually spend a tremendous amount of time in the veterans hospitals. They have to live there. They're all there all the time because they don't know how to live independently, and they're not being helped to do that. And then the GALA program for health advocacy is also geared to help survivors be more involved. One of the interesting things we found from the GALA program is that becoming a health advocate is very therapeutic for people who are survivors. It gives them something to do with what they've learned through the process of dealing with serious disease, and it gives them a sense of purpose to help other people. So, becoming an advocate and providing opportunities for advocacy is really great for giving people a way of communicating in a meaningful way, giving them purpose and helping them reintegrate into life. All right, end-of-life care, last one. Transition from active treatment to end-of-life care has become very difficult, as I talked to you about what's happening in the VA. We don't talk about it, we're uptight about death. People don't want to deal with it. The biggest problem with hospice is that most of the people who need it don't ever get referred to hospice, don't get hospice care. More people die in pain and suffering than need to. A lot of people who are family members are not ready for dealing with death. They end up feeling really guilty and experience unnecessary grief because they haven't communicated effectively. We need to find better ways of supporting end-of-life decision-making, not only by patients, but by their caregivers and also by their healthcare providers. It's a relational issue. We need to do a better job with palliative care and symptom management. It's very tough to die with dignity when you're suffering and you're in pain and you're uncomfortable. We need to try and promote greater comfort. We need to provide social support to people. So here are some of the projects I've been doing. Many of them we've talked about already. The Advanced Care Project is basically designed to help doctors communicate better with patients and their family members, getting them all more involved so they can make better decisions about end of life. The GALA program provides opportunities for connecting people who are suffering or maybe end of life and people who have dealt with death so they can share information and support. We're communicating about death across cultures. One of the problems in the U.S. is that there are many different cultural norms about death. based on your upbringing, your background, your ethnicity. And I suspect there are probably very big differences in Singapore between the different major populations in terms of dealing with death, particularly between the Chinese, the Indian, and the Malay people. And it'd be very interesting to see how those different cultures deal with death. Some cultures deal more effectively with death than others. Which of those cultures do you think deals with death effectively? Which ones do you think have problems?
What does it mean by being effective?
Well, they end up dying comfortably, and people feel good about it. They don't feel pain and suffering. Not just the patient, but also the family members. There's some cultures where people are, for example, in the Irish culture, they celebrate death. They have a big party, and they send people over, and they're very happy, and it's a life transition that makes a lot of sense. There's not a lot of the anguish. There are other cultures that they people for years cry and mourn and suffer and never get over it. There's some cultures where nobody will talk about it.
Yeah, in Chinese countryside, in North China actually, when people have cancer, their relatives and friends refer to that as bad disease, and also that they usually keep the information from the patient and then tell them of a nice case of the. For example, you feel stomach pain and then it's stomach cancer, and then they will say that you have inflammation of the stomach, something like that. And then their relatives, friends, and then their neighbors will come to visit, and then that's part of the end of life care. Usually they provide real intensive care. But then a lot of cancer patients will die without knowing that actually they have cancer.
Do you think that's better for them or worse?
I think that they definitely have the benefit of not knowing it. But then it is quite controversial. Because let's say that you say that the first and the second stage, if the patients know about it, and then they can have certain kind of information seeking and then active participation in their treatment process. But then on the other hand, it seems that the local custom is like that.
One of the problems I see is that if they don't know that they're dying and they don't know what's going on, they can't make good plans. Kind of like it's very paternalistic. It's like, we're not going to let you be in charge. And I think one of the keys I've seen to comfortable dying is having people in charge of their death, and plan it out and know that their family is taken care of, and take care of unfinished business, and say goodbye to everybody.
That might be very Western, though.
Maybe that's obviously my perspective.
Yeah.
My guess is that the person doesn't want to feel like a burden, and the understanding is that they won't be stressing out about it and transferring that burden onto their family and the rest of it. So it's a very sort of group.
I think the critical advice that normally is given to doctors is to see what their patients want to know and how much they want to know, but not to presuppose that they can't handle it or they can't use the information.
See, in this case, there is such a great cultural difference between because there the doctors would choose to talk with the family members first, and then usually take the assumption that the family members will make the best decision of whether to tell or not to tell the patients the real situation of the disease. And usually, if it is the terminal disease, then the family members will not tell.
To add on, right? Because usually in the Chinese culture, usually the senior people, they will receive more respect from the family members, right? But then once they've been diagnosed as a patient, suddenly they don't have that kind of autonomy, and then suddenly they have to just kind of give it up, or purposefully, intentionally or unintentionally, then the family members would take over and then make decisions for them. And
Yeah.
in that sense, actually, they just lost that kind of autonomy to make any decisions for themselves or to communicate with the family members, because now all the decision making seems to be between the healthcare providers, the physicians, and the family members.
Yeah.
One of the things I see as a difficulty with dealing with disease in general is kind of a lack of control, a lack of autonomy. That you lose your identity, you lose your seniority, you lose your job, you lose your all these things, and I find that can make people very disoriented.
And
So-
it's especially uncomfortable for the male, seniors in the Chinese culture, because I saw, how my grandparents died and my grandfathers, right? Because they used to play this role like the opinion leader of the family, and then they received so much respect. And then suddenly, they down there, and then they couldn't even went to the washroom themselves. And you can feel that kind of, embarrassment that they have, and then the discomfort due to the loss of control and the loss of.
I always think about the Native American where they say today is a good day to die, and that means that they're in control of their death, and they know when they're dying, they can plan it out. I like this idea of being in charge or being in control, and not being confused or misled. I don't know.
Isn't that saying also saying that, acknowledging that what it is about death is that you're actually not in control when it happens, right? I would think that saying is also trying to say that it's actually beyond your control.
Or that you recognize it's happening and you know it's happening, and you're okay
Yeah.
with it.
And I think a lot of people who don't want to know would rather be in control of their life than in control of their death. Because I think that, you start defining yourself by your cancer, right? And everything revolves around your cancer, and rather than, I think there is something to be said about, if you don't know, you live your life and you're in control of your life, and you live your life defined as, and you are more than your disease, So I kind of go back and forth on
Although your death is a really important part of your life.
Right. Sure.
The time that I see that death has been most comfortable is when people see it as a conclusion, as a transition, as a final phase, and they're just kind of saying goodbye in a very comfortable way. I find that when death becomes most problematic, particularly for family members, is when they haven't resolved issues. They never told them they cared about them. They never, reconciled over problems, and then they hold that guilt for a long time. I wish I told them goodbye. I wish I told them that I loved them. I wish we had, reconciled.
I wonder if there's a study to be done with in the Chinese culture, whether or not the person who hasn't been told comes to understand that they do have it. There's something else going on here. Other people are acting towards me. that
Yeah,
doesn't
because
happen.
this generation, when
Yes.
they receive a
Right.
kind of like, when they are children do not tell them,
Right.
they might be, when they are young, the ones who keep the information from their parents. So at the end of life, that some of them realize that, and then the neighbors, when they secretly discuss this, they will say that it's double deception. So basically, kids keep the information from the parents, and the parents would say that I don't know, pretend that I don't know. So it's a kind of like a social
Everybody
drama.
knows. It's a social. Everybody knows.
Yeah, social drama of mutual protection. Even.
Sure.
I know, but it seems like it's so complicated.
It's
find
the
that that's a-
relational aspect rather than
Yeah.
Yeah, and then even for this automatic agency that I decide what I do with my life, when it's automatically handed over to their family members, I consider it as from individual agency into collective agency. That people, if this guy knows that he has a terminal cancer, then maybe it will become that, you know, what do you think of your, what do you want to tell us, and then what do you want us to prepare for your funerals, things like that. But then if the information is kept from him, the neighbors can come and say that, you know, China just launched another satellite and it's really great. Something that is totally irrelevant to the disease, and thus, you know, to detour, like kind of look.
Instead of your neighbors just being there to talk about your cancer. Right?
Yeah, exactly.
Or just to say goodbye, you know, just say we're here and we show you respect and your admiration for the people.
Yeah.
No, I always prefer the more direct route. My own family, my father was dying from stomach cancer. Nobody in my family wanted to acknowledge the fact that he was dying. They didn't want to talk about it. And my sisters and my mother would say, "Oh, you look so good, you know, you're doing great." And he was like fading away. You know, there's no way he was looking good. He was dying. It was clear, but they didn't want to acknowledge it. And he knew he was dying, but it made him feel like, you know, he had to play along because he didn't want to make them feel bad. So they're all playing this kind of game, and when it was so, you know, I didn't want to play the game. I just said, you know, well, you know, I acknowledged that, you know, he was dying and told him I love him. He felt like really relieved, you know. But my mother was really mad at me, you know, like I was being disloyal, you know. But then very shortly after that, he passed away, and he was able to let go. But I think a lot of times people are holding on because they don't want to let people down. They, you know, I think it's unfair to the person who's dying if we're not honest and straight with them. Anyhow, it's probably a more complicated thing, but that was my perspective on it. All right.
Just a question. Do you find in general that religious people tend to be more comfortable with dying or death?
It depends on the religion.
It depends.
Yeah. You would think that it would be, especially because you know, the religious people will you know, comfort dying people as part of the religion, or go to services and funerals. And,
Yeah.
one of the things that I wanted to focus on is finding meaning in the journey, helping people to make sense of life and death. I think that uncertainty becomes one of the biggest issues, and we need to help people work through their concerns about life and death, to come to some kind of a conclusion. All right, this is a model that I've borrowed from the Canadian Cancer Society. It basically says that if we're going to understand the role of communication in healthcare, that we need to do a wide range of different kinds of research. Basically fundamental research, so we have theories and models to guide us. Surveillance research to kind of track and see what people are doing. Intervention research to basically try to make changes. And then synthesize knowledge from these different forms of research into applications and program delivery and policies to achieve the healthcare goals. And here's my big follow-up fun slide. This is what I'm trying to accomplish: develop the infrastructure for rapid advances in knowledge about health communication, test new strategies, models, and tools to disseminate research results to different audiences, and implement best communication practices through discovery, development, and delivery. That's my position. I'm going to stick by it. So, I'm sorry it took so long. This is a lengthy one, but I'm hopeful that, you know, that some of what I'm talking about is of relevance to you and your own research programs. I really think that studying health issues has tremendous value, and we have a great role that we can play in minimizing pain and suffering for people in many situations. And I've been really excited to hear about a lot of the projects that you guys are doing here now.
I have just a very quick question. I've heard a few care presentations already, and also in this one, this point was stressed that the research shows that there's an obvious relation between assertive and active consumers or patients, or clients, in relation to the healthcare and survival rates and etc. health standards. I'm just wondering whether that is more of a correlation rather than a causal relation.
Yeah, I'm not sure if it's causal or not. I'm not really
Yeah.
suggesting that. But if we know that that correlates,
Mhm.
then you'd want to try and promote better outcomes.
Mhm.
You'd want to have whatever factors relate to it. There, I think that there are maybe many different factors.
Yeah.
And there may be some predisposition factors that maybe people who are more actively involved or have a better attitude, maybe more stronger people to start with. Maybe the people who are less involved are the ones that are less physically, able to confront disease. But if we know that the more people interact, the better the outcomes are, I think that it's probably a good idea to utilize that. It's like any of the medical regimen strategies, is it's all based on case evidence that when this happens, these outcomes go. We don't know if it caused it or not, but we know that it still varies.
Yeah, because other factors I could think of is maybe people who tend to be better educated tend to be more assertive, maybe tend to have more money also to spend and more engaged maybe also with these new media solutions. Though perhaps it is an issue of relative privilege in which these patients already find themselves that is the actual cause of their better health outcomes.
I think it's access to relevant information that is really strongly influenced by class, education, and socioeconomic status. So one of the things I think we need to do is to try and to provide better access to people who are not part of those privileged populations. I think it will change the outcomes. And we know that the poorer, the less educated, marginalized people are more likely to suffer and die. And they're the ones that have the disparities in health outcomes. I think there's a big communication dimension to that. In fact, I feel kind of a sense of responsibility that if we're not trying to rectify these information inequalities, then we're basically reinforcing these negative outcomes. It's like the old saying that if you're not part of the solution, you're part of the problem. And if we have specific, expertise to try and provide good information, and design strategic information campaigns, and develop interventions and programs and policies, I think it really behooves us to do it because we can help people.
I have no doubt that for a lot of people, good information, has these positive effects. As I listen, I wonder, especially since you're doing a lot of international work now, I wonder if this is a lack of access to information is primarily a privileged first world kind of problem. Other places that you have all the information in the world, but sporadic access to care and other ecological, environmental problems, and et cetera, et cetera. So I wonder how you are thinking about modifying this information, primarily information approaches.
I've been doing a lot of work more and more in poor and under-resourced countries, and although there are inequalities in access here, and there are parts of China where that's really a big problem, I think people learning about where they can get access and how to work that system more effectively and what they can do on their own helps to mediate those structural problems. So, information is not just self-educating people, it's also helping them access opportunity and to make good decisions and make the best of the opportunity. Thank you. So I think that even the low-roast, and maybe even particularly, people need more information than not to help them deal with those structural barriers that exist. And it's not just content information, it's also relational and support information. A lot of people feel very alienated and disconnected. And sometimes because of the nature of the healthcare problem. They're just kind of like off on their own and they need help. They need help to kind of get what they need. And also it's not just access, but it's also voicing. I think that it's not just like we need to help people become better receivers, we need to help them have more voice. To say, I don't like the way this is set up. I want healthcare in a different way. I want other resources and empower them to go after it and get it. Yes.
Yeah, I have a question about Hint, especially Hint China. So I wonder how your group access China. Is that through government organizations or
Yes.
non-government organizations or
My
hospitals?
research partner is the Ministry of Health
Okay.
in China. The director of health education
Mhm.
for the country, Mr. Mao,
Mhm.
is my primary research partner.
Mhm.
And the Ministry of Health is doing the collection of data. I help them redesign the survey and give them strategies for data analysis and interpretation. But they're conducting the study.
I see.
We
Is it-
also have some universities that are working with us,
I see.
particularly Renmin University of China.
Mhm.
They have a big public opinion research center.
Mhm.
And a fellow named Professor Guoming Yu,
Mhm.
is our primary research director for this project.
And the research sites mainly cities or countryside.
We have broken it down by every province
Mhm.
in China. I think there were 43 of them. So we have it geometrically matrix so that we're getting representative data from every area, both urban and rural. So we'll be able to break things down based on the unique problems that people have in different parts of the country.
Mhm. Okay.
150 scholars, right? You said?
What's that?
Did you say 150 scholars or something like
Yeah,
that?
somebody said, I don't know where that came from. There's a lot of people collecting data. We're collecting those data in personal interviews.
Great.
We're doing 100,000 personal interviews.
Wow. Wow, that's a lot.
Pretty intensive.
Yeah.
So I'm really excited to see those data there in the field now. In the next few months, we'll have those data and we'll start analyzing it.
Great.
It'll be really exciting.
Great.
And then we're going to have to sit down and talk about what can be done to try and make things better.
Mm.